course on the cataract comorbid capsule, and I'm thankful to the scientific committee for allowing us to present this course year on year. And here our aim of this course is to try and share different conditions where the cataract surgeon will probably need to team up with his colleagues, be it retina, be it cornea, or at least get an overall view of how to approach cases which have not just cataract but other comorbidities which will affect the long-term outcome of such eyes. With us, we have a stellar faculty, Dr. Aditya Sudhalkar, who will be talking about role of steroids in uveitic cataracts. Dr. Vanda Nath will be talking to us about pterygium and cataract, which is very common in our part of the world. We have the master, Dr. Rajesh Fogla, who will be talking to us about managing cataract with corneal dystrophies. And also, we have a very young and dynamic retinal surgeon, Dr. Shail, who will be talking to us about managing diabetic macular edema in patients undergoing cataract surgery. And I'll be sharing with you certain helpful tips in cataracts with corneal opacity. So without any further delay, I'll invite Dr. Aditya Sudhalkar to talk to us about tackling the uveitic cataract.
Thank you very much, Dr. Shail, and as always, it's an honor and pleasure to be a part of this course. As already mentioned, cataract, a standalone cataract surgery is a very rewarding surgery. But when there are comorbid conditions, and specifically if I may talk about uveitis, there are several other factors which will influence the outcome. And the traditional thought process that patients have of clear vision, expedited recovery the next day often doesn't take place. So thankfully, there are a lot of advances, both technological and pharmacological, which help us give patients almost the same outcome, if not the exact same outcome that they would have with a conventional cataract surgery. So this is just something, and this patient was advised cataract surgery elsewhere. The report said old cells and flare, but there was very active uveitis. This was a monocular patient with very evident vitritis and fibrosis synechia in the anterior segment as well. So in the first step to the handling of a uveitic cataract is control of inflammation. So I'm just going to have a couple of case illustrations to put things in perspective. So this was a 57-year-old lady. This is a separate case, of course, who presented to us with decreased vision in the left eye since a month. She had a similar complaint 1 year ago, which resolved with some local therapy, and was diagnosed to have macular edema elsewhere, and had been given topical NSAIDs. So she sought a second opinion. FFA was done elsewhere and was diagnosed to have cystoid macular edema. The vision, as you can see, was affected in both eyes, but especially the left eye. And in the anterior segment, there was obvious posterior synechia with cells, active cells and flare, as well as vitreous cells. So this is the picture that we see here, and what you see there is actually exudates and a lot of edema as well with subretinal fluid. So this is just a succinct picture to show the course. So as you can see, I don't know if you can see do we have a pointer? But initially we treated the patient for uveitis. So she had posterior uveitis, and that resolved with the dexamethasone implant. Subsequently, she developed a cataract, underwent uneventful cataract surgery, had a recurrence post-cataract surgery, and was treated with a second injection. This is yet another lady who again had been advised cataract surgery elsewhere, but had also complaints of blurred vision, metamorphopsia, and so on and so forth. So the angiography and the OCT scans confirmed the presence of cystoid macular edema, which could only be explained by posterior uveitis. She underwent first treatment again with the dexamethasone implant. As a rule, we try and avoid systemic therapy as far as possible. And eventually, we found out that the husband had a course of AKT 10 years ago. She herself had a positive Mantoux, underwent AKT, a full course, and eventually was diagnosed to have cataract, and she received both a combined cataract and intravitreal injection. So in the interest of time, I'll just skip through the photos. But anyway, the third thing that we have to remember during cataract surgery, apart from the inflammation, of course, is there are other challenges. For example, posterior pupillary synechia, additional instrumentation is required, such as iris hooks or pupil expanders. Often the capsule is fibrotic. there's a posterior capsular plaque, there might be associated vitritis, which may make the view a little murky. And most importantly, any recurrence in such eyes can be extremely intense. So a period of quiescence ranging anywhere between 3 to 6 months is desirable before we opt for cataract surgery in uveitic patients. And this is the prime example of this patient. So everything else resolved, but then he had this epiretinal membrane. It was diagnosed. Ultimately, he needed vitrectomy and membrane removal. The edema persisted. It was only after the implantation of an intravitreal dexamethasone implant that the edema subsided to give a satisfactory reaction. So we have had the fortune of conducting a randomized trial. It was a sponsored trial wherein we compared the dexamethasone implant with systemic steroids. So just skipping to the results in the interest of time, both groups showed excellent visual gain throughout. Most importantly, there was only one recurrence in the dexamethasone implant group out of 20 or 23 patients who needed intervention with systemic steroids. Otherwise, all patients, when we take into consideration the period of quiescence, were managed very well solely with local therapy and not with systemic therapy. So the whole goal is to prevent systemic side effects of oral immunosuppression and concentrate as far as possible on the tissue which is involved. Now, I'm just going to show two videos because this is an increasingly common situation. The first shows how to combine an intravitreal dexamethasone implant with cataract surgery. So at the end of the surgery, generally it is given in the inferotemporal quadrant, bevel facing downwards. And we choose to remove the viscodispersive, any dispersive viscoelastic that you have after injection, because it helps seal the ports of entry during cataract surgery. And it is then that you finish your hydration. If these rules are not followed, the second video shows how not to inject and what to do in case you have a problem. So here, as you can see, the lens is going in. Now the surgeon chooses to remove the viscoelastic prior to injection of the dexamethasone implant. And if you see the position of the bevel, you will see it shortly in the lower part of the screen. The bevel is facing upwards. The direction of the needle is not vertical or perpendicular, it is towards the capsule, and eventually the dexamethasone implant lands up in the posterior capsule. Now, because the surgeon was extremely skilled, he was able to do a reverse optic capture, and ultimately the patient had an excellent outcome. But this is a scary situation, and for a moment you can go blank. So the best is just to stick to the basics, stick to your the technique, and make sure that you don't have to face this situation at all. Now I keep repeating, talking about the dexamethasone implant, but obviously in India not everybody can afford it, and so subtenon triamcinolone or even intravitreal triamcinolone is a convenient and effective alternative and a cheaper alternative. The subtenon route, and we have found it to be very effective. It's just that it has to be in the right plane. So we actually do a conjunctivotomy and a tenotomy and go in with a visco cannula to inject triamcinolone in the subtenon space. So this has two benefits, as per our experience. One is you are in the subtenon plane. Number two, there is no chance of perforation because you are not using a sharp instrument. And ultimately, if it is in the subtenon space, there is a very little chance of any IOP spike. So overall, if you look at our paper, and we have collaborated with several European institutes, there were about 152 eyes that received overall 358 dexamethasone injections. The mean gain in BCA was quite satisfactory, and more than a third gained 15 letters or more. 40% patients eventually needed cataract surgery, and the approximate time from first injection to cataract surgery was about 11 months. Nearly a quarter of those patients needed IOP lowering therapy, but no one received incisional surgery for glaucoma. So steroids can be both given perioperatively in pseudophakic patients, in anti-VEGF resistance, and so on and so forth. But the most important thing is local steroid therapy is the current focus. So I thank you all for your attention, and I would love to take any questions.
Excellent presentation, Dr. Aditya. Aditya, we as cataract surgeons, predominantly doing cataract surgery, are very scared that, if the patient has had uveitis for multiple episodes, synechia, should we put the patient on atropine post-operatively? Should we start him 3-4 days prior on oral steroids and continue it? So what's your take on all of that?
So if the uveitic part has been quiescent for at least 3 months or so, we can readily combine the patient's cataract surgery with some form of intraocular therapy. It can either be an intravitreal dexamethasone implant, or it can be intravitreal triamcinolone, which is not preferred because of the high IOP, right? And if the patient cannot afford a dexamethasone implant, a subtenon triamcinolone injection is very effective.
So I think one of the important take-home messages that I gained from this talk is that the role of heavy dose systemic steroids in a relatively quiet uveitic eye undergoing cataract surgery may not be necessary, particularly keeping in mind the age group at which most of these patients are getting operated.
Keeping in mind their systemic comorbidities.
Exactly.
So systemic steroids can readily be replaced. In fact, let me give you a reverse example. So we were recently treating a sympathetic ophthalmitis case. Obviously, one-eyed patient, the other eye was lost to trauma or something, and that's why she developed. So the patient had received pulse methylprednisolone therapy, 1 gram for 3 days, and was on systemic steroids. Even then, the lumpy, bumpy appearance of the choroid that we described had not disappeared after 10 or 15 days of intense therapy. We put in one intravitreal dexamethasone implant, which in Gujarat is sanctioned even by the Gujarat government in certain cases. And within 4 days, the choroid was flat. So the role of local therapy cannot be overemphasized. It is not only a very good addendum to systemic therapy, sometimes it suffices as sole therapy.
Thank you so much for that wonderful insight, Aditya. I'd now like to invite Dr. Vandana Nath, and she'll be sharing to us how we can, improve our outcomes of patients undergoing cataract surgery with pterygium, which is quite common in many parts of India.
Good afternoon, everyone. Thank you, Shail, for this opportunity in this stellar conference. All of us are bothered by pterygium, especially when you have a patient undergoing a cataract with the comorbidity of pterygium. How do I know whether it's going to impact? Now we are dealing with two things. We are dealing with a cataract and we are dealing with the pterygium. How do we know whether it's going to impact? Because any pterygium gives rise to some amount of astigmatism, some amount of aberrations. So what is going to be, how are we going to calculate the biometry, and what is going to be the choice of the IOL for giving a good refractive outcome to our patient? I cannot underestimate the value of the pre-operative evaluation, where you go like a resident and do the history, visual requirement of the patient, understand what is the patient's vision requirement, status of the fellow eye, and the most important is the counseling. So there are only 3 options. Either you do only the cataract surgery, leave the pterygium alone and operate it later if it progresses, operate the pterygium first and later the cataract, or combine the pterygium and the cataract surgery. So let's take option 1, where we do only the cataract surgery, and these are our own cases. This is a 76-year-old lady whose left eye we had done a flax with a toric IOL, and now we are undergoing the right eye. Now she's undergoing the right eye surgery. This is a juicy grade 3 nuclear sclerosis, which we are ready to pounce on. But she knows that she has a long-standing pterygium, and patient is okay. It has never bothered her. So ideally, when we do the keratometry, we should have at least 2 different keratometry readings. You can use your optical biometers, and you can use for regularity of the astigmatism, you can use topography or a Scheimpflug imaging. Excuse me. And look for the regularity. For regularity must have this bow tie kind of a pattern that you see in the topography. Now this is thank you. These are the keratometry readings where you can see there's a minimum astigmatism between the steep and the flat axis. But even the small pterygium is not giving a very regular astigmatism. If you see this pattern, and this is actually the aberrometry profile, which I'm showing you now. And you see, not only there is a minimum astigmatism, but that circle shows coma and trefoil. These are the higher order aberrations on the cornea, which even this small pterygium can cause, okay? These are the things that cause the dysphotopsia in unhappy patients. And it has been known in literature that pterygium and its size have significant influence on the higher order aberrations of the eye. So we selected the IOL based on this patient's profile, based on this patient's eye, and we were not compelled to put a toric IOL in this because she has a minimum astigmatism, and we did a simple monofocal IOL with a 6/9 corrected with a minimum of residual astigmatism, which she was okay with. This is a case too which was very challenging to us. Absolutely doesn't want a pterygium surgery. He's a very active businessman. This is the maximum pupillary dilatation of this patient, and therefore he has been able to function with this kind of a pterygium. To make matters worse, he is nearly one-eyed. The right eye, if you can see, he has a multifocal IOL with an iris atrophy and a full thickness macular hole on the OCT, which we always do even with the fellow eye, even if it has been operated elsewhere. So coming back to the left eye, she has a very high astigmatism of you can see this K1, K2 readings, nearly 5 diopter of astigmatism. So what is the best we can do? Now, if you notice the dotted black line, we wanted to tell ourselves that now this is a sort of a astigmatism which is showing a reasonable bow tie appearance. So can we reduce this person's astigmatism at least to give him a little better outcome? So yes, we did plan a toric IOL, and we used the Barrett's toric calculator. And we implanted a T9, and he is very happy 6/6 vision with a minimal residual astigmatism of 0.75 diopters. So this was the best refractive outcome that we could give him in spite of this long-standing huge pterygium that he had with a very high astigmatism. Now this is the second option where we do a staged surgery. Which are the conditions where we do the staged surgery, where we do the pterygium first? This is a 57-year-old female with a fleshy pterygium and very high astigmatism, again of nearly 6 to 7 diopters. So we advised her to remove the pterygium first. And this is the surgery with a conjunctival autograft, which we always do with tissue glue. And we lowered the astigmatism and then planned a toric IOL with a regular astigmatism, and patient was counseled and given lubricants, 6/9 unhappy. This is just the surgical procedure. You can do whatever method you are comfortable with, and this is how we just peel it off and do a measured, this is the way and I've learned this surgery from watching Dr. Fogla's video. Dr. Fogla is here with us for the next talk, using tissue glue. And the next case is self-explanatory. This was a lady who had a huge recurrent pterygium. And yes, I did call up Dr. Fogla to find out what should we do with this patient. So he said, obviously, you need to take out the pterygium first. And this is the first week post-op where you can see the large conjunctival autograph. And he had warned me that you will have a lot of scarring. So please warn this patient. And yes, we did warn this patient that she did have. But she was ecstatic because from CF 1 meter, her vision improved to 6/18. So we advised her to wait for 6 months at least for the corneal topography to stabilize and then put a spherical IOL, a non-aspheric IOL. And she was very happy with her 6/9 vision. So post-operatively, these are the patients where you want to keep a close watch, repeat the keratometry, wait for the keratometry readings to stabilize. And this was the case where we wanted to wait ideally for 6 months. And pterygium excision can significantly reduce most of the higher order aberrations, and topographic changes take time. So for any case where you have done a pterygium, at least wait for 6 to 8 weeks before you operate. If they are small and do not impact the keratometry readings, they can be left alone. If they are large enough to adversely affect, remove the pterygium first and then plan. The option 3, I'm not going to advocate from this platform because I'm going to show you examples of what can happen if you combine the cataract and pterygium surgery. This is a lady who was sent by the optometrist because she has never been comfortable with glasses. So the optometrist told her that, no, I can't do anything. You please get your cataract done. And you can see that there's hardly any cataract. And I'll show you, it's a double-headed. This is the aberrometry profile. And if you see this corneal profile here, all the aberrations that are coming from the cornea. the high astigmatism and the higher order aberrations. The internal, which is the cataract, is hardly any aberrations. And this is the quality of her vision. So which is the deterioration of the quality is because of the cornea only. So we had explained to her and we made her undergo, this is the high astigmatism, 5 diopters. So this is before we did the pterygium surgery. This is what we are getting, the toric T8, okay? And this is post-op, day 1. This is 2 weeks post-op, and we waited. This is after 2 weeks, all the aberrations on the cornea are gone. Her vision quality has improved. So we wait for 3 months and then do the surgery. And this is what I'm showing you, that if you had combined this pterygium with the cataract, what IOL you would have implanted. Even if you are going for a monofocal, you would have done a 24 diopter. So with the change in keratometry, not only did the spherical diopter change from a 24 diopter to the 22, but look at the toricity from T8 to T2. So you've had a very bizarre refractive outcome if you had combined this surgery. This is the last case, 65-year-old female. She's having this pterygia double-headed pterygia since 1 year. So it is a recent onset only. And if you notice, this is a thin, a thin pterygium with vascularity with this growing edge that you see. And a good grade 3 cataract as well. So again, these are all the aberrations, including the cataract related and the corneal. This is the poor quality of her vision. And this is the surgery that we performed. This is another trick I learned from Dr. Fogla, is to reverse the beveled blade, the 15-gauge blade, to reverse it and peel it off. Because I know this cornea was not very scarred, and this pterygium would not have been very adherent to the cornea. So I reversed the blade and just peeled it off. This is post-op day 1. All the aberrations are gone. And this is the quality of her vision with just the pterygium removal. This is post-op day 10. And this is now her biometry that we got with a T3. And this is what we implanted. And 1 month post-op, she is 6/6. And we waited for 5 months after the pterygium to do this. So the insights are ocular wavefront aberrations constitute the quality of vision, and topography is a must. We advocate a pterygium surgery first if it's impacting the K readings, and we do not advocate combined surgery. Thank you so much.
Thank you, Dr. Vanda, for that excellent array of cases. And I think the most important take-home message is counseling, because both the patient as well as the surgeon are in a hurry to operate the cataract. We are in a hurry, particularly if it's summer season, you don't have any list for next 2 days and the patient is willing for cataract. Hold the brake and follow all the principles that Dr. Vanda has shown. So, and the second is that the patient quite often is not very much aware about his pterygium. He's just come prepared that, no, I just want cataract surgery, forget pterygium, this I have since many, many years. And however benign he may look right now, post-operatively, if he doesn't see well, he's not going to accept whatever excuses or whatever explanations that we are going to give them post-operatively. So I think the aberrometry profile as well as the topography is not only useful for us scientifically to document, but also to explain to the patient that not all of his problems are due to his cataract, but most of his problems are due to the pterygium or the irregularity that is occurring due to the pterygium. And not all of his problems will be solved just by either alone pterygium surgery or pterygium followed by cataract. So lowering down the expectations of such patients is also extremely important. But I'd also like to value Dr. Fogla's comments on how you would, sir, approach patients with pterygium and moderate cataracts, which can also wait for a while.
Well, if you're looking at premium lenses and you want to give your patient the best refractive outcome, I think a stage surgery is the best approach. And with the current patient's expectations that we have, every patient wants to have good visual acuity after the surgery. It makes sense to remove the pterygium. So cosmetically, it looks great, and you can get better IOL power calculation, and you can give your patient better outcomes.
Thank you. Please, ma'am. Please.
How long do we need to wait post-cataract surgery? Post-pterygium surgery. Yeah, at least 6 to 8 weeks. But if it is large and across the pupil area, please wait for at least 6 months, as I showed you. Yeah.
Okay, so now we move on to the highlight of this course, Dr. Fogla's talk on how to approach cataract surgery in eyes with guttates or Fuchs dystrophy, frank, early, moderate, so on and so forth. Over to you, sir.
Thank you, Shail, for making me part of this course. And I'll be talking about cataract surgery in eyes with a lot of guttate changes like Fuchs dystrophy. I have no financial interest to disclose. Fuchs dystrophy is a bilateral condition that affects the endothelium, seen as the guttate changes that starts in the central cornea, has an autosomal dominant inheritance, so you will definitely have a family history. Presentation is usually in the age group 50-55. Clinically, you can see that orange peel appearance, especially with advanced guttate changes. If you do a specular microscopy, you see a lot of dark spaces where the cells are missing, and on anterior segment OCT, you will see a duplication of the decimus membrane, and also the decimus become highly reflective. Now, the way the disease progresses is that you get guttate, you get polymorphism, pleomorphism, increased thickness, then you get these bullae formation, subepithelial fibrosis. Patients with Fuchs dystrophy may also have symptoms of glare, decreased contrast, blurred vision, symptoms which are quite similar to cataract. And at that age group of 55, 60 years, sometimes there are lenticular changes as well. So what happens is often if you're not very careful, this can be mixed, and you can, in a dilated pupil, you'll just see the cataract and you'll straight away go ahead do the cataract surgery. But if you were to see both the guttate changes and the cataract, then the clinical decision comes as to how are you going to proceed with the cataract. Whether you're going to so it all depends on patient expectations and the clinical findings. So the pachymetry, endothelial cell count, and the clinical symptom of early morning blurring of vision, that can be used for decision making. In a normal population, the corneal thickness in majority ranges between 500 to 600. And with the present tomography devices that you have, you can pick up early changes of Fuchs dystrophy where you find that on the posterior elevation, instead of elevation, you find a depression. That means you find that the posterior cornea is actually going towards the anterior chamber. And also the thinnest point is no longer in the apex, it gets displaced, and the central cornea becomes thicker. Like in this case, if you see the right and the left eye on top, if you see the right eye, you see the posterior elevation, you see there is a large area of depression into the anterior chamber. This can be used for monitoring patients over a period of time to see whether the Fuchs dystrophy is progressing. Cataract surgery, you have a normal cell loss ranging anywhere from 8 to 10% depending on the density of the cataract, the anterior chamber depth, and the pupil dilatation. And usually in compromised endothelium, the soft shell technique of using both a dispersive and cohesive viscoelastic has been described to protect the endothelium. And if your pre-op pachymetry is more than 640, you have a 22% rate of the cornea decompensating and need for corneal surgery. Now, in these kind of patients with guttate changes, if you were to go ahead and just do the cataract surgery alone, the advantage is that you avoid the complications associated with endothelial keratoplasty. The need for post-operative medications is reduced because if you do an endothelial keratoplasty, patients have to use steroids for a longer period of time. They need to have more frequent follow-up visits with the cornea specialist, and the visual disease can progress over a period of time if you just leave the Fuchs dystrophy alone. So these need to be discussed with the patient because sometimes the guttate changes are such that they are not very advanced and the cataract is not very dense, so you can get away just by doing a cataract surgery alone. If you were to decide about the cataract surgery, currently the phacoemulsification is the preferred technique, but with a very dense cataract, sometimes you may resort to doing a manual small incision cataract surgery or an extracapsular cataract surgery. If your patient has a very shallow anterior chamber and a dense cataract, maybe doing a limited pars plana vitrectomy can help increase the space in the anterior chamber whereby you can minimize the damage to the corneal cells. If you are going to put in an IOL, aim for a little bit more myopia, because when you do an endothelial keratoplasty, this will offset the hyperopic shift that you see. Don't choose a hydrophobic IOL, because in endothelial keratoplasty, don't choose a hydrophilic IOL, because in endothelial keratoplasty, we use air or gas for tamponade, and hydrophilic IOL can develop opacification. So always choose a hydrophobic monofocal, preferably aspheric. During surgery, use sharp knives, because the decimates can sometimes, because it's thickened, the adhesion may not be very great. So use of blunt knives can result in detachments, either near the main port or the side port, which can lead to intraoperative detachment of the decimates. I prefer to suture the wound rather than to, hydrate the wounds, because in this kind of scenario, sometimes when you hydrate, the hydration itself can cause a detachment of the decimates. So to secure the wound, place sutures, leave a mid-size air bubble, so that if you have caused any detachment of the peripheral DM near your incisions, this air bubble will help reposition that detachment as well. Post-op steroids has to be used more frequently. Sometimes if there is edema, use sodium hydrochloride, sodium chloride for 2 to 4 weeks, monitor the IOP. And if there is corneal edema, don't panic. Give 8 to 12 weeks of time, because sometimes the edema may resolve over that duration of time. If your patient already has pre-existing corneal edema or a lot of guttae which extends all the way to the periphery, or significant amount of changes which makes endothelial cell measurement not possible, then maybe a combined surgery is a better approach. So for me, I use corneal thickness and the endothelial cell count as a decision making. So if the cell count is less than 800 and the thickness is more than 600, 650, and the patient is over the age of 50, I will recommend a combined surgery rather than going sequentially. Now, usually we use the central corneal thickness as an indicator of the endothelial function. It's a surrogate marker. When you cannot measure the endothelial cell count, you fall back on looking at pachymetry. So if you look at the central and pachymetry, normal pachymetry increases from center to periphery. So there is a ratio between the central and peripheral corneal pachymetry. If this ratio starts reducing, that means the central pachymetry starts becoming as good as the peripheral. That again is a marker to say how your Fuchs dystrophy is progressing. So this is something, that index, that can be used. Newer OCT can also, if you cannot image the endothelial cells, the new OCTs can give you a 3-day imaging of the endothelium, which can show you how rough how much of guttae changes you have and how widespread it is. If the guttae changes are only limited to the central area and you have peripheral cornea, which is relatively reasonably okay, you can do a procedure that's called as decimate stripping only. In our population, because our patients are not that symptomatic with the early changes, sometimes we don't see this, but in the West, they have been doing this procedure where they just remove a central 4 to 5 millimeter area, where they remove the decimates with the guttae, and the peripheral cells slide over a period of time, and they result in central clearing, especially with the use of Rho kinase inhibitors. So in these kind of cases, you can do this procedure first, and then you can go back and do a cataract surgery if the patient has significant lens changes. But if you have a cornea which is like this, where there is already significant corneal changes, then you have to do the endothelial keratoplasty. It's better than the traditional penetrating keratoplasty. You get better refractive outcome, lower risk of rejection, and if you combine it with the cataract surgery, IOL power calculation is better. So basically in this surgery, you strip off the host decimates, which has all the guttae changes. The cornea decimates is thicker. This is removed, after which you can do either a DSEC, where you can see you are taking in a donor lenticule which has about 80 to 100 microns of corneal stroma along with the donor endothelium. So once you get the disc into the eye, you let it unfold, and then you put a large air bubble to put it in position. In DMEC, you basically put in the isolated decimus membrane, which is stained with trypan blue. You have a S or F stamp to identify the orientation. Then using the surface tapping, you can get the graft to open up and put a large air bubble. Combined surgery with IOL cataract surgery and DMEC have shown reasonably good refractive outcomes. This is one of my patients. One eye, we did the phaco IOL DMEC, and a week later, using the pair eye of the donor eye, we did the second eye because the first eye had recovered so fast. So you can do the second eye. You don't need to wait long term. You can do the second eye surgery much more frequently. Cataract surgery, pseudophakic bullous keratopathy, if they don't clear up in 8 to 12 weeks, you can go ahead do a DMEC surgery. Or if you have a younger patient with Fuchs, you can do the DMEC first and then come back and do a cataract surgery. This group, they have shown performing a DMEC surgery, performing a cataract surgery post-DMEC, the endothelial cell loss is not much, and you can achieve well within the plus or minus 0.5 target of the refractive outcome. So basically, that's a flow chart showing you the different things that you can do. In conclusion, you have newer diagnostic methods to quantify the corneal changes in Fuchs dystrophy. So not just the central guttate, but looking at the overall picture, the thickness, the posterior elevation, and the extent of the guttate changes going all the way to the periphery. Choice of procedure depends on patient expectation. Patient is expecting a toric IOL or a EDOF IOL, wants better refractive outcomes. Maybe do a sequential procedure where you do the DMEC first and then come back and do a cataract surgery. In future, you will have cell-based therapy, cultured cells, which will help us manage in the management of Fuchs dystrophy. Thank you. Thank you for your patient hearing.
Superb masterclass, sir. On that, I think one of the most important take-home message that I learned from this talk was also keep looking at the pachymetry, because what quite often happens, sir, is that some patients have very nice chunk of central guttates, rest of the cornea is clear. If the optometrist has captured it on an auto mode, not really checked what kind of cells have been picked up for count, you may get a cell count which is 0 or no cells found, or 200, 300, where actually the rest of the cornea is quite strong. So I think that's a very, very important take-home message, that don't rely just on blank specular microscopy printouts. Look at how those cells, how many number of cells have been counted, and learn to analyze the specular microscopy report. Just don't look at what the number that has been written there. And so like we discussed in pterygium, that first do pterygium and then cataract. With your tremendous experience with endothelial surgeries, would you recommend that you're sure this cornea is going to decompensate, but would you still recommend first do cataract and then few months later desec DMEC to improve the outcomes of the transplant, or you find combining it is equally
combined
predictive?
Surgery is reasonably good. It gives good.
Yes.
So by doing a triple procedure where you do phaco and then do a IOL, it does not reduce the the efficacy or the outcome of the DMEC.
Yeah.
But if you had a aphakia or a lens where you go do a scleral fixated lens and then you want to do a DMEC, maybe in such scenario, doing that lens exchange, scleral fixation first and then come back and do a DMEC may be a better choice because of increased manipulation and the post-op inflammation that you have. For one just small caveat, that if you do a cataract surgery and your patient has corneal edema post-surgery, don't be in a hurry to refer for a DMEC surgery, because sometimes you may have compromised endothelium, but the endothelium still has some capability to recover. So treat with steroids, control the IOP, use hyperosmotics, and the best way to assess prognosis is do OCT, anterior segment OCT, look at the pachymetry maps. If you see a reduction in the pachy over a period of time, then you know that this cornea is going to recover. But if you don't see any change, or if you feel that the cornea thickness is increasing, that means that this patient may require an endothelial keratoplasty.
Right, sir.
So, unfortunately, we see a lot of very advanced PBKs finally who are coming to us, and these bulli have ruptured and they have had history of corneal ulcers with hypopion, which we treat medically and then advise them for surgery. With so much of superficial corneal scarring, we do desec, but yeah, that opacity, the epithelial and the subepithelial scarring sometimes doesn't improve at all.
Yes. I completely agree with you that in these eyes, if you do an endothelial keratoplasty, you may have a suboptimal visual outcome. But then location of these opacities, if they are not exactly in the center, if it was bang in the visual axis, maybe I would consider doing a PKP. But if they are not exactly in the visual axis, we can always go ahead, do an endothelial keratoplasty because it's minimally invasive. Post 3-4 months later down the lane, I can do a topo-guided PRK to further smoothen the surface. We have had patients who are comfortably wearing rigid contact lenses and they're able to see better. The absence of sutures and the reduced risk of rejection definitely gives us more advantage. And in case the patient does have a suboptimal outcome, it does not change the prognosis for a subsequent PKP.
Thank you. Thank you, Dr. Fokla.
Thank you, sir, once again for this wonderful masterclass. Now I'll invite Dr. Shamal Dwivedi, who is a brilliant, dynamic vitreoretinal surgeon, and he's going to talk about something that is becoming more and more prevalent, diabetic eye disease. As the longevity is increasing, as our lifestyles are getting worse, and particularly from where we come, Gujarat, it's the diabetic capital of the country. So we face this dilemma quite often. Significant cataract progressed rapidly due to diabetes, but the OCT shows macular edema, and he's going to share with us how we need to approach these patients scientifically.
Thank you for involving me in the IC. Thank you for the kind words, Shail. Good afternoon, one and all, and I am here to discuss how to deal with the diabetic macular edema along with the cataract. So as we all know, India is set to be a diabetic capital by 2020-30, and as we all are aware that it's a dreaded complication contributing to the burden of the society. And now, without going into much of the theory and statistics, we will directly come to the point, treating cataract and the diabetic macular edema. So there are two approaches or two ways to do it. The first approach is targeted to treat the macular edema first, dry out the macula, and later followed by cataract surgery 2-3 months later, once we are sure that the macula has remained dry for some time. And the other way is treating cataract and diabetic macular edema together with appropriate intravitreal injections or surgery, which is known as the combined approach, which we are currently interested in today's IC. So these are some indications of the combined approaches, but we don't want to go too much into all these details. Moreover, it is already proved that diabetic macular edema worsens if a diabetic patient is undergoing a cataract surgery, and thus managing that diabetic macular edema efficiently remains our primary goal. So this slide is again self-explanatory, but the main point to highlight is the need to join hands with a vitreoretinal colleague or for an appropriate diagnosis of diabetic retinopathy. We are again not going into the theory part of the diabetic macular edema because we are quite familiar with it. And as most of us know, these are the well-established diabetic macular management options. But the intravitreal injections are the most popular and widely used in today's era. So now let us come to the real world scenarios. So our eminent team member Dr. Aditya Sudhalkar was involved in the trials related to the dexamethasone implant, and they concluded that dexamethasone implant is a valid option in treatment of diabetic macular edema patients, those who have not undergone any treatment or those who are treatment naive. So here is our first case showcasing a cataract and a diabetic macular edema secondary to a non-proliferative diabetic retinopathy. So this patient was successfully had undergone phacoemulsification along with the dexamethasone implant, and even at the end of 3 months, the patient continued to maintain decent visual acuity and almost regressed diabetic macular edema even at the end of few months. This is a second case. This gentleman is a one-eyed patient and has an inoperable TRD in the right eye, and the left eye, the only seeing eye, has a diabetic macular edema along with the cataract. So this was a responsible task for us, and this surgical video of the same patient undergoing a phacoemulsification and IOL implantation. Once the IOL implantation is done, as Dr. Aditya Sudhalkar mentioned, that it is very important to keep the anterior chamber filled up with viscoelastic substance, and 3.5 millimeter from the limbus the measurement is taken, and the direction of the needle should be towards the center of the globe. So once it is in the center of the globe and the two planar entry is encouraged, once the implant is inside the globe, we are able to visualize the implant through the pupillary plane, and it is extremely important to see that implant through the pupillary plane so that we are satisfied where exactly the implant has gone. So once the things are finished, AC, BSS wash and site is massage, and that is marks the end of the procedure. So for the same patient, the post-operative result was very satisfying, and he had an excellent visual acuity of 6/6. Further, if you see, the patient also underwent a focal and a grid laser. You can very well see the regression of the hard exudates on the right side of the photograph. This is the previous pre-cataract surgery photograph, and if you see after the focal laser, there is a marked decrease in the hard exudates and thereby preventing future injections as well. This is a third case, and this patient was posted for a cataract surgery, and it looked like a normal fundus to everybody of us. However, the OCT had a different story to tell, showing both eyes having a diabetic macular edema. So he was subjected for a fundus fluorescent angiography to identify the reason for the macular edema. And so once the FFA was conducted, it documented a moderate type of non-proliferative diabetic macular edema, retinopathy, along with the macular edema, which was correlating with the OCT findings. Again, the patient was subjected for cataract and dexamethasone implant, which proved very fruitful for the patient, regaining a full visual acuity gain. This is a fourth case, and this patient with a diabetic macular edema was posted for a left eye cataract surgery, but this case was little different. And on fundus examination, it was clear that this patient has a proliferative diabetic changes. As you can see in the red-free image, that there is a neovascularization over here with a lot of capillary non-perfusion areas. We are more interested in the left eye of this patient. However, both the eyes had a proliferative diabetic retinopathy chain, but we were operating the left eye, so let us concentrate on that. This was a partially lasered diabetic retinopathy case, but this laser was not good enough to regress this NVE over here, and that is the reason we had to do something for this. So this was clearly not a case for a steroid implant, and this patient underwent an anti-VEGF injection along with the cataract surgery, and later we could see a total resolution of the NVE, and this is the area of capillary non-perfusion, which was further lasered with a PRP addition and some amount of focal laser as well. So this patient did very well in long run, maintaining a good visual acuity. So this is the fifth and my last case, and this case is very close to my heart. He is a young photographer and a young diabetic having all sorts of diabetic complications, and he presented with this picture showing a thickened posterior hyaloid, epiretinal membrane, diabetic retinopathy changes. These were proliferative diabetic retinopathy changes and some amount of subhyaloid hemorrhage in the left eye as well. So OCT showed a massive diabetic macular edema with a taut posterior hyaloid and an epiretinal membrane in both the eyes. The patient was subjected to different intravitreal injections before taking the patient for a cataract surgery. We wanted to make sure that the patient is free from diabetic macular edema. We tried different injections. The patient was given several injections, first dose, second dose, third dose, trial of mix and match of different anti-VEGF. But in spite of many injections, the right eye did not respond, but on the contrary worsened. However, the left eye behaved well after the treatment, and it was the responding eye. So this was clearly a surgical case, and now we went ahead with a combined procedure with phaco and a vitrectomy. So after a successful phaco implantation and in the bag IOL implantation, a 25 gauge pars plana vitrectomy ports were constructed. He is a young diabetic, so we expect that the vitreous to be very, very firm and very, very adherent to the surface. So in this patient, we used triamcinolone. So triamcinolone assisted PVD was the aim, and in spite of trying many times, PVD induction was proving difficult, and at one point of time, I started losing patience. However, by continuous backup and encouragement by Dr.Shail and our senior Abhay Vasavada sir, I finally got hold of the PVD. As evident, the triamcinolone particles are coming up, and finally I achieved the PVD. And later on, after achieving the PVD, there was nothing more to do. Our aim was only to achieve a PVD, no ERM peeling, no ILM peeling, absolutely nothing. We just wanted to relieve the traction. We later on added pan-retinal photocoagulation to the retina before closing the case, and it was very, very satisfying to see a complete resolution of macular edema, and this eye never required any treatment for the right eye. We have 2 years follow-up of this patient without any treatment for the right eye. The left eye continued to respond very well to the intravitreal injections, and he is still on the left eye intravitreal injection. So our take-home message is it is very essential to identify the correct diabetic retinopathy stage and make the patient understand about their own condition, as diabetic retinopathy is a very complex disease. Now the time has come where we need to join hands with a retinal colleague for a better customized approach for the patient. And last but not the least, dexamethasone implant is an excellent choice for patient undergoing cataract surgery with diabetic macular edema in most of the treatment naive patients subject to proper evaluation. Thank you very much for your attention and engagement throughout this presentation.
Thank you, Dr. Shamal, for sharing those wonderful case-based presentation. And I had one or two questions for you, Dr. Shamal. Quite often, many of these patients have a significant enough cataract that we cannot, wait for 3 months, 6 months, etc., for the diabetic retinopathy to stabilize. And often, you and with your retinal colleagues suggest that first we want to make sure that this retinopathy stabilizes before you do any surgery. So, say for example, you decide to give an intravitreal injection and a cataract surgery is planned later. How much is the time duration, minimum time duration you would suggest? 1 week, 1 month?
So it again depends on what amount of macular edema or what type of retinopathy it is. But if you ask me, I would wait for 2 to 3 weeks before doing any cataract surgery or any other procedure onto the eye.
And when you're combining an injection along with cataract surgery, is there a preference of any one kind of injection over the other in terms of choosing either an anti-VEGF more over a steroid or vice versa, or it still depends on the type of retinopathy picture?
So basically, if it's a non-proliferative diabetic retinopathy and if we are combining with a cataract surgery, dexamethasone implant stands out. And if the things are different, because there is no much IOP rise, patient retina behaves very well with the dexamethasone implant, and it gives a sustained release for up to 3 months, taking care of the diabetic macular edema. But however, if it's a proliferative disease, I would reconsider and go ahead with an anti-VEGF. However, if we are not combining it with a cataract surgery, the scenario is altogether different. I would see the profile of the patient, how the retinopathy is, and probably my first choice would be an anti-VEGF injection.
And quite often we have patients who've undergone, 2 or 3 injections. We waited for cataract surgery. The VIA surgeon now you feel that now the disease is stabilized and now you can go ahead with cataract surgery. So if the macular edema is stabilized and the patient is undergoing cataract surgery with no actual macular edema at the point before cataract surgery, would you still recommend combining it with an injection in such eyes which have had repeated treatments already before?
So if there is no documented macular edema, I would refrain and just wait for the macular edema to appear once again. But if there is a slightest doubt, even slightest thickening, then I would go ahead with a dexamethasone implant or whatever is suitable for that patient at that point of time.
And pre-operatively, to us as cataract surgeons, would you recommend starting these patients more frequently or well before surgery on NSAID eye drops or something like that, or they don't help much in diabetic macular
So there
edema?
was a study I read a few days back, and they say that it doesn't really make a significant change even if you put on a non-steroidal anti-inflammatory drug. What helps is, like, diabetic patients tend to have a smaller non-dilating pupil or less dilating pupil, or pupil which would constrict immediately as soon as you enter the AC or something like that. So it would probably help a diabetic patient to sustain that pupillary dilatation. But I am not a fan of NSAIDs, and I usually don't give it to my patients.
Thank you so much for those wonderful cases.
Thank you.
So I'll be sharing some of the challenges that I've encountered in operating patients with corneal opacities. So we do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. This was a 74-year-old female, one-eyed, known case of corneal opacity in both eyes since childhood. Her right eye, which is the lost eye, has been operated for PK twice and probably has had an old funnel RD in that eye for many, many years. And the patient has somehow managed all her life with this left eye that is there. Now, when she presented to us, we got a call from the referring surgeon that the better eye, which was being operated, capsulotomy was attempted and probably completed. a first chop was being attempted, and then because of the poor view, the surgery was rightfully and correctly stopped at that point, closed the eye, and decided to refer in the best interest of the patient. So when she presented to us, she had hand movement vision. PLPR was accurate, fortunately, in all quadrants. This is her clinical examination. Even in bright light, both the cataract as well as the cornea were almost completely white. So it was difficult to make out if any rhexis was actually completed, not completed, half cut, split. We had no clue what was going on. The corneal thickness, like you can see, is not very high, which means that this is not an endothelial disease per se. It's just a corneal bad opacities, which may have been smallpox induced during her growing period. And this is the other eye, which has had a failed graft multiple times and funnel RD in that eye. So the better eye, which we are planning to operate, which is, halfway in the surgery, has an attached retina, but that is most important to see, because if that is not there, the entire plan changes completely. So while starting the surgery, we've seen and we've learned quite often from corneal colleagues as well as expert surgeons to use endo illuminators from the sides to try and help and visualize and see if we can find out any clear areas that are there. But even with the endo illuminator from the side, I'm really struggling to see if there is any area of capsulorhexis or any flap that I can see. So I gave up the idea of the endo illuminator in this case right from the beginning, and I thought, let me first stain and see if some stain picks up. And if you notice here, some fluffy matter is already getting released, which means at least there is some opening somewhere, and I could get a rough idea that this is probably the area where part or at least complete capsulorhexis has occurred. The rest of the capsule has taken up some stain, and this is the area where probably some amount of a small capsulorhexis has been done, and it's a white mature cataract. So I decided to take my chance, and in this area of the opening, very small area, I'm slowly but surely sculpting and trying to divide this nucleus, because I've realized now that this cataract is very, very brittle. So it's behaving like a liquefied mature cataract. I was hoping that it would be a little dense so that I can chop, but it wasn't very dense. So I'm making sure I'm trying to bring the fragment towards the central area, which is the area where I know that the capsulorhexis is open, and I'm very conscious of making sure that my chopper remains posterior to whatever the capsulorhexis margin is. And I'm going to make sure that my right hand doesn't go anywhere except for this very small central area where the capsulorhexis is open. So whatever maneuvers that need to be made with my left hand. I'm also very conscious, because I don't know, this rhexis may split somewhere, it may have an extension somewhere. So I'm keeping my parameters very low. So very low intraocular pressure of 20, which is equivalent to a bottle height of about 35 centimeters. A very low flow rate, less than 20. And a moderate vacuum appropriate to the density of the cataract, so about 300 to 350 vacuum. And slowly but surely, I'm bringing it in the middle, subdividing this relatively soft nucleus and removing it as much as possible in this central safe zone that I'm able to see. And even with this editing, this this surgery took really, really long, and a lot of sweating as well. And fortunately, most of the nucleus I feel now is out through this central area, and now I can at least see some sort of reasonable kind of glow and some sort of cortex that I'm able to see. So now, while removing the cortex, this is the case where definitely bimanual irrigation aspiration has a distinct advantage, because you are able to access and ergonomically move your probes in all different directions, whether it's subcapsular or below the corneal opacity, by keeping your other hand free. And here, swiping movements are extremely important. You don't want to pull too much because you don't know about the zonular integrity as well. And only after I bring the cortex to the center will you see my vacuum building up. So when I'm actually in the periphery and notice few chips of cataract are also coming, and therefore I'm having to crush them with the irrigation probe into the aspiration probe. Some of them do get dispersed off in the angle while removing this cataract. So making sure that the cortex is removed decent enough, at least from whatever I could see, and even before changing hands, I do inject dispersive viscoelastic to make sure things are okay. So this is the picture. I can see some amount of opacities. I'm not sure whether it's in the anterior capsular area or it's on the posterior capsule, but most of the entire capsular bag looks to be open. And therefore, I did decide to go ahead with IOL implantation. We had counseled the patient for aphakia and all possible complications. But because I'm not sure about the integrity of the capsule, as well as what is going to happen during IOL implantation, I decided to go ahead with a 3-piece IOL in such a situation, because it is likely to be the safer option if I have to go to plan B, or if I have to, if the IOL even ends up in the sulcus, a 3-piece design with PMMA haptics in the sulcus will be a much safer option. So I'm using the injector and using my proprioception to dial the intraocular lens in the capsular bag, and I'm notching here with the Lester hook to look at whether the capsule is actually covering the intraocular lens, which I felt it was doing quite okay. Any incision more than 2.2 is a great idea to suture, but definitely in such an eye with such a compromised cornea, it's a great idea to suture even a 3.2 millimeter incision, and you'll notice that I've taken 2 sutures here to make sure that there is absolutely no leakage from the wound occurring. I'm doing viscoelastic removal now, and I get some sort of sense of some amount of, making sure that this part was actually subcapsular on the anterior capsule margin and not on the posterior. And I noticed a small nick in the anterior capsule, which fortunately had not extended, which I now converted into a capsular excess margin. So if I can go back and, sorry. Yeah, so this is how the patient did, quite okay, reasonably. The uncorrected was 660, best corrected was 618 parts, but she's extremely happy. So obviously such eyes are not going to have the 6669 kind of vision, but functionally she was much better off than what she had been in the last 3-4 years. Because naturally, patient was also very scared of getting operated, being the only seeing eye, and so with so many surgical difficulties. This was another 70-year-old male, both eyes nebulomacular corneal opacity diagnosed since a very long time, both eyes cataract, a brother of an ophthalmologist, practicing ophthalmologist, who's been seeing him for all his life, and known case of very high myopia as well. So all conditions combined, a bad cornea, a bad retina. He's been using myopic glasses of -13 ever since he was 18 or 20 years of age, and his visual acuity is only counting fingers 2 meters. So he referred to us for cataract surgery, and this is how the patient looked. This is the large central corneal opacity that the patient has. Fortunately, if you turn it on the retroillumination, you can get a reasonably decent view. But if you actually see it on diffuse illumination, it's quite a dirty cornea, particularly in the area where we are going to do cataract surgery. Keeping in mind the risks of penetrating keratoplasty, we discussed with the patient and we decided that we'll attempt to do a cataract surgery, and if everything goes off well, if he's reasonably okay, nothing else later. And if nothing works out, then maybe a penetrating keratoplasty at a later stage can be considered. So all this haze that you see is the corneal haze and not actually the cataract or the cortical opacities that you often see. And I think however good you may feel initially, these are the cases where staining with trypan blue is of paramount importance, because you will need that intraoperatively as well when the surgery is going on. So if you notice here, I'm struggling to see centrally whether any nick has been made or not, and therefore in the area where the opacity gets over is where I'm trying to position the flap, which I can then manipulate to my ease. And I don't want to make a very large rhexis here, because I'm aware that if my view intraoperatively gets bad and if I end up with a a relatively serious complication, I need a good anterior capsulorhexis support as well to consider. Once again, many of these cataracts are not very dense. They are more cortical and more fluffy in nature. Like I'm realizing now, it's neither here neither there. So it's not very soft and not very dense to chop very easily. But keep following the principles, keep the occlusion on, and use lateral separation as much as possible to try and break this cataract into multiple small pieces. Again, use very low fluidics, low intraocular pressure. Here it's 20, but you could keep a 30, 40, whatever is more comfortable, but keep it lower than your normal, and a very low flow rate, because it is the flow rate which is going to decide what and how fast you are going to attract. So even though your cataract surgery may occur faster with a higher flow rate, you have also very high chance of catching unforeseen things like the iris, like the posterior capsule, like the anterior capsulorhexis, which again is not very visible in this eye. After the lens was removed, I ended up in quite often what we end up seeing is what is known as this plate, which is not amenable to IA, where there is no anterior cortex to catch, and therefore you'll notice I've turned my bevel downwards, having reduced the power now to only 20. And having turned the bevel downwards, I've occluded it and kind of prolapsed it into the anterior chamber. And once that prolapse occurs, once you occlude it facing bevel down, that's when you can easily remove it. IA, once again, as I mentioned, it's very important to use bimanual irrigation aspiration in such eyes. Occlude, swipe, and only once you get to the center will my vacuum actually go to 250, 300. Until that time, it will always remain between 50 to 100, because we want to aspirate in the center and not in the periphery where you can catch anything as well. So again, swipe, you can get larger areas of cortex at one go, as well as you'll be putting less stress on the zonules as well. And such eyes, obviously, there is no question of considering toric or other forms of IOL. A simple spherical monofocal IOL is of the most paramount ease. After the IOL was in place, I realized the rhexis was much smaller, and such eyes may have inflammation post-operatively. So chances of phimosis are higher, and therefore I'm increasing the rhexis size, what was described by us many years back as initial small and definitive large, and going ahead with viscoelastic removal. The patient recovered reasonably well, has good functional and ambulatory vision, and the patient, and fortunately the ophthalmologist, is also very happy. So I think proper assessment on a case-to-case basis, like we have for endothelial diseases, here I don't think there's one good go-to chart which we can follow, that if this is there, do this. So on a case-to-case basis, decide on the type of cataract, the location of the corneal opacity, the one-eyed or bilateral-eyed nature of the patient, how long he's been living with this opacities. All of these things are extremely important. The aim in these surgeries is to provide a functional vision, and we are not looking at refractive outcomes and other things. I think great credit does go to the newer generation microscopes. If you turn on your full coaxial illumination, it's astonishing that what you saw on the slit lamp where you thought, how am I going to operate? But on table, you do see reasonably well through the new generation microscopes. Trypan blue use is of paramount importance. Use tricks like using endo illuminators from the sides, and several surgeons have shown using chandelier illumination from the back to increase the glow that you see by keeping the microscope off. And counsel, I think that is most important. Do not operate at the first visit. See him once, even though you want to operate him, you're going to operate him. Call him back in 1 month. Ask him to bring his other relatives also. Counsel them at least 2 or 3 times for the prognosis, as well as the possibility of multiple surgeries, ending up with a drop nucleus, ending up with a PK, so on and so forth, and prepare them for the worst before operating them. So thank you so much for listening to this talk, and I would value Dr. Fogla's comments on how you would think of approaching patients with corneal opacities like this, which are not endothelial diseases per se.
So the mic is there.
See, I completely agree with you because a lot of these patients are elderly patients and they come back and the opacity is not of recent onset. The opacity may have been there for long duration and they are coming to you because of the development of cataract. They are finding it difficult. So they are not expecting 6 by 6. So you are completely right in your approach that first remove the cataract and if they are happy with that vision, it makes life much more easier for them than to do a cornea transplant combined with the cataract because that requires much more post-operative management, care and the risk of rejection which can take away the vision whatever he is recovering. But one small point that I wanted to make was in these kind of cases where sometimes if you really feel that phacoemulsification is a little bit more challenging, maybe doing a manual small incision cataract surgery may be a better option for somebody who is not as skilled as you and so because that thereby you just make a capsulotomy, prolapse the nucleus and bring it out, you can still achieve the same because with limited visibility it looks good when you start out with the red glow, but once you hydrate and you're dealing with the nucleus, the red glow goes away and then if you're not able to crack the plate, then you're in a dilemma as to how far you can go.
Excellent point, sir. Any other comments from
Yeah, one question in the first case. Even though I knew that the outcome was good, even while watching it, my heart was still in my mouth right now. With an open capsule, somebody has already attempted a surgery earlier. You don't know the integrity of the capsule. Will you change your choice of viscoelastic? Would you go for a heavier or would you continue with the same viscoelastic? Would a heavier be more detrimental?
So yeah, the excellent question is that if you use a very heavy cohesive viscoelastic, say Helon 5 or Helon GV, that itself can be detrimental for the fact that if there is a nick or if there is a split, that heavy viscoelastic itself may increase that split further. So I would definitely not go for an extremely heavy cohesive viscoelastic, particularly until I'm reasonably sure or reasonably confident that there is a strong opening in the center.
Thank you.
Yes, ma'am, please.
So this is Dr. Vasavada from Kolkata. So for the second case, the way it looked like a stable refraction, and it was more of an stromal epithelial opacity. So you left behind you targeted a functional refraction, but why not a refractive outcome, like leaving behind a -2 cylinder? Like if the patient had been economically, could provide for it, would you have opted for a toric lens?
So the toric, the problem or the advantage of a toric or the disadvantage is that it works only for a regular astigmatism. So these patients, I should have probably got the topography and the pentacam as well. These have very irregular corneas. So there is no regular astigmatism of 90 degrees where you can decide which place the IOL would be able to correct it. So in any case of irregular astigmatism, it is best to avoid a toric IOL. So the cost was not an issue for this patient. In fact, we charged much more than we would have charged for a normal toric IOL for him.
Even if the astigmatism was stable, for irregular astigmatism, you would...
No, so any irregular astigmatism, whether it's stable, unstable, any irregular astigmatism, no toric IOLs. Okay, so I think we are run out of time for the course. Thank you so much, everyone, for staying back in this lunch hour. And thank you so much, sir, for coming and gracing our course. Thank you so much. Excuse me.